Hello everyone, this is Dr. Meenakshi Gupta from the Conceptual Pharmacology. Today I have come with another topic of pharmacology, that is anti-anginal drug. So these are the drugs which are used to terminate the attack of angina. Not only terminate, but it is also used to prevent the attack of the angina. So the drug which are going to prevent or terminate the attack of angina. Now, what is angina pectoris? So, this one is derived from a Latin word angre and pectus. Angre is to strangulate and pectus is chest. So, it is translated as a strangling feeling in the chest. And why that strangling feeling in the chest is there? That is due to the ischemia. The cause is ischemia. Ischemia to what? Ischemia to the myocardium or ischemia to the heart muscle. That is the important cause. And because of the ischemia, there is a reduced blood flow or reduced oxygen supply to the heart. Now, how many type of the angina pectoris we have? We have a classical or a stable angina. Then we have a variant or prinzmetals, and then unstable angina or pre-infarction angina. So out of that, classical or stable angina, that is the most common. Now what is the cause of classical or a stable angina is, so classical or stable angina, the most important cause is atherosclerosis of coronary artery. So this is the number one. So because of the atherosclerosis, what will happen? Because of the atherosclerotic block, now the blood supply to the myocardium, it is atherosclerosis of what? Coronary artery, the artery which is going to supply to the heart. So because of the atherosclerotic block, what will happen? The artery will be stenosed. More than 70% will be stenosed. So blood supply will be reduced, or it is going to cause the ischemia, or oxygen supply will be less, and that is going to cause the ischemic pain. Now another one is, if this myocardium, it gets enlarged or hypertrophied myocardium, then what will happen? There will be increased demand. Because of that, there will be increased demand of the myocardium. So because of the increased demand, now hypertrophied myocardium will be because of, if we have to exert the pressure for pumping, like in aortic stenosis, इसमें आपको जोर लगाना पड़ता है. Then if the person is having hypertension, then this myocardium, it gets enlarged, and now the demand is increased. So this is the cause. Now you can see atherosclerotic, this is the heart with the epicardium, that is this coronary artery you can see on the heart. So this coronary artery, it is going to supply to the heart. How it is going to supply to the heart? So these are the three layers of the heart, from outside to inside. Outside it is a epicardium, then we have a muscle layer, that is a myocardium, and then we have a endocardium, and this is the epicardial artery. This here it is a epicardial artery, and here is the block, atherosclerotic block, which is going to block this artery. Now this artery, it is going to supply to the all the layer, this myocardium and subendocardium. So below this endocardium, it is a subendocardial zone, and this is the zone which will be affected maximum. That is, it is going to produce the subendocardial ischemic zone. Okay, so this area will be maximum ischemia will be here. So now you can see here, now because of the reduced blood flow, so this portion, because of the ischemia, reduced blood flow, this is going to decrease the less oxygen will be there. Now the person will be getting the ischemic pain, and because this ischemic pain, what will happen, this is going to patient, what kind of the pain patient will be feeling, it is like a pressure or squeezing type of the pain will be there, which will be radiating to where, which will be mainly radiating to the left arm, आपकी left arm में जाएगी, then it is on the jaw, ठीक है, neck, jaw and shoulder, and there will be along with that in the angina pectoris shortness of breath will be there and excessive sweating that can happen. So this is in the stable angina. Now again coming back to the and all these symptoms, they are going to last for 20 minutes, and what will happen once the person take rest, then all these subsides. Now coming back again to the previous diagram, this I have taken from the KD Tripathi. So you can see here during the angina, and it is in between the attack. Now what does it mean in between the attack? You can see in between the attack, this figure where all the layers they are shown, it's perfectly fine, and where here we are seeing the subendocardial ischemic zone. So what happens in between the attack? That means in between the attack, the person with the classical angina is normal. So block, it is still there, but the patient is not, or person is not feeling any pain. It is because of the ischemia. What happens to this resistant arterioles or resistant artery? They get dilated. ठीक है, ये वाली जो artery है, they get dilated and blood flow to this area is fine, is okay when the person is doing his routine work. But what happens when the person is doing some exertional work, like exercise, person is doing any exercise or any kind of exertion or any stress, then what will happen? Now the body demand, it is increased. Heart is not able to meet that, and that is the time when the person is going to get the angina. So what happened in classical angina? I again repeat, in classical angina, though this adenoma, it is fixed, but as such the person won't be having any pain throughout the day or any, if the person is doing his routine work, because now what happens, the ischemia, it causes the dilatation of this blood vessels. So this area, it is getting enough blood and enough oxygen supply. But what happens during the exertion, during the person is taking any stress or any exercise person is doing, now the demand, it increases, but the blood, normally what happens if the demand increases, the blood vessels, it gets dilated. This gets dilated, and this area, heart will be getting enough blood supply. But now because here atherosclerotic block is there, and this area, it is already fully dilated because of the ischemia. So when the person is taking any exertion, the further chances of dilatation of these blood vessels, it is not possible. Now this is the time when the person is going to get the ischemic pain. That's why in between the attack, the person is normal, or you can say there is a no pain. It is only during the exertion patient will be having the pain. This is in the case of classical angina. I am talking about the classical angina. That's why the classical angina, it is also called stable angina or exertional angina, because the pain is only during the exertion. Now coming to the second type of angina, which is, so this is a stable angina or classical angina. Another name is classical angina or exertional angina. So this is on taking the rest, the patient will get the relief. Now number two is unstable angina. The patient will be having a pain even at rest. Pain is at rest. It is not at all related with anything or any exertion or any stress. Now here, what is the pathophysiology of unstable angina? That clot which was there in the blood vessel. I'll show here the cross section of the blood vessel. So suppose this is a blood vessel. This is a lumen of the blood vessel. Here is the atherosclerotic plaque, And now this is the lumen, only this portion it is left from where the blood is going to flow in the stable angina. Now in unstable angina, what will happen? This block, there will be breaking of this block. Okay. Now this block, it is broken, and what will happen now? The platelet and all that will be deposited. Now the lumen, which was earlier lumen was this much. Now what happens from here to here? How much lumen is left now? It is only this much. Okay. So pain, and it is going to again compromise the blood supply. Now this is an emergency unstable angina. So you have to, because this is also called pre-infarction angina. Why it is an emergency? Because the patient or person is prone, very higher chances of going to the very high chances of going from unstable angina to the myocardial infarction, or you can say the heart attack. But what is the basic difference between the unstable angina and the myocardial infarction? So in unstable angina, this is the unstable angina and this is the myocardial infarction. Here still the patient is having the ischemia, and here it is a not ischemia, it is an infarction, or you can say the necrosis. Then the enzyme, myocardial enzyme, that is increased level of, here no the occlusion of the coronary artery is not complete. Coronary artery occlusion is incomplete. Here it is complete, and here next is no rise in myocardial tissue enzyme, which shows the damage to the myocardium, like we can see the troponin level. Okay, here there is rise in the will be seen. Rise is present. And then further the ECG finding. It is no ST segment elevation. And here it can or it cannot. हो भी सकता है और नहीं भी हो सकता. This is the difference between the unstable angina and the myocardial infarction. Now coming to the third type of the angina, that is the Prinzmetal angina or a variant angina. So variant angina or a Prinzmetal angina. Now what is in a variant angina or Prinzmetal angina? Here usually the cause is spasm to the coronary artery. Now because here it is a spasm, so spasm means what will happen? All the layer of the heart, this epicardium, myocardium and subendocardial zone, all will be ischemic. So all these layers will be ischemic in the myocardial. So this is the coronary artery. Now what will happen in the variant angina? There will be complete spasm. So heart won't be getting the supply. Now why you must know all this pathophysiology? Because if you know the pathophysiology, the treatment part, it becomes easy. Now in classical angina, what happens? It is only during the exertion when the demand is more. Now what kind of the drug you are going to give, which is going to decrease the work of the heart? Whereas in case of the variant angina, you are going to give the drug which is going to cause the dilatation. of the coronary artery. Because here the person will be feeling the pain. It is not at all related with the work. Because of the spasm, the patient will be feeling pain at rest or exertion. It is not at all related with any kind of activity. So the drug which will be beneficial in the variant angina are those which is going to cause the coronary artery dilatation. So this is all about the three type of the angina. Now what we can give for the treatment? So we have the anti-anginal drug. So you can see here the classification of the anti-anginal drug. We have nitrates, we have a beta blocker, calcium channel blocker, potassium channel opener, and newer anti-anginal drug or miscellaneous anti-anginal drug. So in today's video, I will be covering only nitrates. So this is one kind of classification, and another one is clinical classification. So already I have told in the beginning, the anti-anginal drug, they are the drug which is going to prevent or which is going to abort or terminate the anginal attack. Now out of this nitrate, they are the one which we can use prophylactically as well as for the treatment. So prophylactically kaun si karni hai, which we can give by the sublingual route. Whereas rest of the drug, nitrate, it is used for both prophylactically as well as for the treatment. Whereas rest of the drug, they are used only for the treatment. So this is the clinical classification of the anti-anginal drug. Now coming to the nitrate, you can see nitrate, they are the short acting and the long acting. Under the short acting, we have a nitroglycerin or glyceryl trinitrate, and the second one is a isosorbide dinitrate. So both we are giving by sublingual route. Then we have a long acting isosorbide dinitrate. We can give it by oral route, mononitrate, erythritol tetranitrate, and pentaerythritol tetranitrate. Then we have a amide nitrate. Under the beta blocker, we have a non-selective as well as selective propranolol, metoprolol, atenolol. Whereas under the calcium channel blocker, we have a verapamil, diltiazem, amlodipine, all the dihydropyridines and non-dihydropyridines. Potassium channel opener, we have a nicorindal. Then here we have a metabolic modulator, trimetazidine, ranolazine, ivabradine, and dipyridamole. Now coming to the first group of drug, that is a nitrate. Now how this nitrate, so whenever we are talking about any drug, so one thing always remember, you should always know a little bit about that drug, introduction part, how this drug it is going to act, mechanism of action, important pharmacokinetic feature, where we are going to use, and what are the important adverse effect. At least these are the important points you must see whenever you are reading any of the drug. Uske baad, if you can remember the pharmacological action, because this is the one, the extension of the pharmacological action, that is okay. And if you want to write any contraindication or any important drug interaction in that particular drug, so you can memorize that also. Now introduction part, where the nitrate, it was used many years back, we are using more than 100 years, and now also we are using, okay. And what we found, this nitroglycerin, it was found to give a transient relief in angina, and this was seen in the workers of explosive factory. So nitrate, it is an important component of the bomb or explosive factory. Now how this drug it is, this is a little bit about the nitrate. If you write only the introduction part, nitrate, it is an important anti-anginal drug, that is also more than sufficient. Now how this group of drug it is going to act. So this again I have taken this illustration from the KD Tripathi. Once you give the nitrate, what will happen? It is going to cause the release of, this is the nitrate, any nitrate you give, GTN, glyceryl trinitrate, or you give isosorbide. So mechanism of action of all the nitrate, they are same. Whatever nitrate you are going to give to the patient, they are going to cause the release of NO first. And this NO, it is going to stimulate the guanylyl cyclase enzyme. And this guanylyl cyclase enzyme, they are going to convert this GTP into cyclic GMP. And this cyclic GMP, they are going to activate protein kinase G. Now this protein kinase G, what it does, it is going to cause the activation of myosin light chain phosphatase. So this enzyme, what it does, it is going to cause the dephosphorylation of the myosin light chain. So reaction will go on this side. So myosin light chain phosphatase, what it is going to cause, it is going to remove this phosphate from the myosin light chain, and you can see this side, the myosin light chain enzyme, it is without the phosphate, and you know the phosphate is the one which is going to cause the interaction of this with the, it is going to interact with the actin, and further contraction will happen. Now what happened, because of the removal of this phosphate, this myosin light chain, it won't be able to combine with the actin. So there will be no contraction. So no contraction of the smooth muscles. So this nitrate, they are taken up by the vascular smooth muscles. What will happen? Their NO, that is, I again repeat, they are taken up by the vascular smooth muscle. Then nitric oxide, that is released, and this is going to activate this guanylyl cyclase, and which is going to cause the conversion of this GTP into cyclic GMP. This is going to cause the activation of this. So number 1 is this, number 2 is this, then this is 3. This is going to cause the activation of protein kinase G, and further activation of this myosin light chain phosphatase, and which is going to cause the dephosphorylation of this, and with the dephosphorylation of this phosphate group, it is removed, it won't be able to interact with this, and further what will happen, there will be smooth muscle relaxation. So another is this cyclic GMP or protein kinase G, both, they are going to inhibit this entry of the calcium. Now this calcium, it is required for what? It is required again for the conversion of this, it causes the phosphorylation of this myosin light chain kinase. So it is going to inhibit. Now no calcium entering will be there. This is another mechanism. Okay, there is no entry of the calcium, it is going to inhibit this. No entry of the calcium, then what will happen? No phosphorylation of this myosin light chain kinase. If there is no phosphorylation, it won't be interacting with the actin, and there will be no contraction. So either way, it is going to cause the relaxation of the smooth muscle. Now how this NO, it is released? So nitrate, they are denitrated with the help of enzyme aldehyde dehydrogenase, right? And another one is glutathione reductase. So these are the mitochondrial glutathione reductase. So these are the two enzymes which helps in the denitration of the nitrite. So this is how this drug it is going to act. So they are going to cause the relaxation of the smooth muscle, especially vascular smooth muscle, and everywhere, all at a different site. Now what are important pharmacological action? If they are going to cause the relaxation of the smooth muscle, then what they are going to do? By causing the relaxation of the veins, they are going to cause the relaxation of veins, and ultimately cause what? They are going to cause the venodilatation. Now with this venodilatation, what will happen? There will be peripheral pooling of the blood. If the peripheral pooling of the blood it is there, it is going to decrease the preload. And if the preload is decreased, then what will happen? The cardiac work is decreased. This is how one. Then it is also cause the relaxation of the arteries. So arteriolar dilatation. Okay, arteriolar dilatation, what will happen? The arterial resistance, it is going to decrease the TPR that maintains the so there will be fall in blood pressure, mainly the systolic blood pressure that will be fall, and diastolic, that is maintained by the resistance vessels. So this is the, it is going to decrease the afterload of the heart. Then the number 3, the collaterals, it is going to cause the relaxation of the collateral or dilatation of the collateral blood vessels. Now because of that, what will happen? Now dilatation of this plus the dilatation of the blood vessels which are present, resistant arterioles which are present in the ischemic zone, because of the ischemia, they are already dilated, and the dilatation of this, it is going to increase the blood supply to the ischemic zone. I'll just explain it with the one diagram, so later on. So this is its main, what are important pharmacological action. Okay, so it is going to cause the vasodilatation. यहाँ पे because of the decreased TPR, it is going to cause the vasodilatation. Now what we want in the angina, especially in the classical angina. In the classical angina, I told you we need a drug which is going to decrease the workload. So it is going to decrease the workload. It is mainly by the decreasing the preload. So cardiac work, that is decreased. So this drug, we can use it for the treatment of classical or stable angina. Second thing is, it is also going to cause a vasodilatation, coronary artery vasodilatation. This is what we need for the variant angina or for the Prinzmetal angina. So nitrate we can use both for the classical angina and for the variant angina. So in the classical angina, this drug, it is going to decrease the workload, whereas in the variant angina, it is going to cause a vasodilatation. So at usual doses, it is not going to decrease the diastolic blood pressure that much, so that there will be reflex tachycardia. So what happens if you are going to give the higher dose of this? Then what will happen? Because of the higher dose, they are going to diastolic blood pressure, and there will be reflex tachycardia, which is going to increase the cardiac work. So this happens with the higher doses, not at the usual doses. This won't happen at the usual doses. This is only at the higher doses. You can see in the next slide. So venodilatation, that is a prominent effect. Decreased venous return, preload is decreased, so cardiac work is decreased, decreased requirement or decreased oxygen demand, so relief of the anginal pain. Which anginal pain? Here it is a classical. Arteriolar dilatation decrease, TPR decrease, afterload, again cardiac work, and it is also going to cause the dilatation of the large coronary blood vessels. So increase blood flow to the ischemic. This is how it is going to helpful in the variant angina. Here important is why I have written here the predominant effect. So nitrate, they are going to cause the dilatation of veins more in comparison to the arteriole. So this is a prominent action. Why it is so? Because of the presence of more amount of aldehyde dehydrogenase in the vein. So nitrate, they gets denitrated with the help of enzyme aldehyde dehydrogenase, which is there in the veins. Okay. Then another is why it is going to cause a dilatation of the large coronary artery in comparison to the smaller one. So large coronary artery, again there is a differential presence of aldehyde dehydrogenase in the coronary, larger coronary artery. It is more as compared to the smaller. So again the reason is Same. Now, this is another figure. So you can see here, this is the conducting blood vessels. Again, the same figure I have, this epicardium, myocardium and subendocardial. This is the conducting vessel. When you are giving the nitrate, what it is going to cause? It is going to cause a dilatation of this larger coronary artery. So now I am explaining this point. This is the third one, the dilatation of the larger. So you can see here, the dilatation of the larger, the third point. This. The dilatation of the larger coronary vessel. Why it is going to be that? What will happen? It is going to cause the dilatation of this nitrate, cause the dilatation of this larger coronary artery. Now the blood flow, it increases. And this ischemic zone here the blood vessel that is already dilated because of the ischemia. So ischemia itself is a very good vasodilator. Now the vasodilatation because of the ischemia and this vasodilatation of the bigger coronary artery because of the nitrate. Now what will happen? The blood supply to this area will be more, because this side here it is no ischemic. This is a non-ischemic zone. So resistance vessel, they are going to maintain the tone. So what happen when we are going to give the nitrate? They are going to cause the dilatation of this blood vessel and blood flow, it is going to increase. Now because this blood vessel, it is dilated, so this is going to get the more blood. Now what happens if there is any drug? If it is not acting on the larger blood vessel, if it acts here on the smaller blood vessels instead of here, then what will happen? Because of the dilatation of this smaller blood vessel, now what will happen? The blood flow which was going to this ischemic zone, now the dilatation of the blood vessel, it happens to even the blood vessel which is supplying to the non-ischemic zone. If the drug, instead of causing the dilatation of larger coronary artery, if it is going to cause the dilatation of the smaller artery, this resistance, non-ischemic, this vessels, then what will happen? The blood flow, it will be more towards here. यहाँ पे ज़्यादा होगा, and what will happen? Flow, it is going to decrease in the ischemic zone. So this phenomenon is called coronary steal phenomenon. It is very commonly shown by hydralazine, and dipyridamole. So dipyridamole, these are the two drugs which is going to cause isoflurane, that is another one. Okay, so that shows the coronary steal phenomenon. This is another important short note. What is a coronary steal phenomenon? So coronary steal phenomenon, they are the few drug, what they do, they are going to cause the dilatation of this resistance vessel. Ye wale. This, they are going to cause the dilatation of this resistance vessel instead of causing the dilatation of this larger blood vessel. Then what will happen? Because now this vessel, they get dilated, the blood flow, instead of going towards the here it is dilated. Now from here it will go to here also. So this is called the coronary steal phenomenon. This is very important short note. Now coming to the pharmacological action, heart, no depressant, no excitatory effect that is seen with the nitrate. Whereas on the blood vessel, it is going to cause the dilatation of the blood vessel. You can see instead of coronary artery, it is going to cause the dilatation. So it is going to treat the decrease the workload, preload, afterload. Whereas in the cutaneous blood vessel, this is also dilated, so causing the flushing. This is important side effect. Whereas this the meningeal blood vessel, they are also dilated, and this is going to cause a pulsatile headache. Whereas the blood flow to these areas, they are decreased. Because it has blood supply, it is diverted towards the heart. Then on the respiratory system, it is going to cause the decongestion of the lung by shifting blood to the systemic circulation. And in the smooth muscles, so this is the one where we are going to use it for the myocardial infarction. So in that, it is going to cause a pulmonary congestion. It is going to take care by shifting the blood to the systemic circulation. Then in the smooth muscles, it is going to cause a relaxation of bronchi, biliary tract, esophageal. So we can use it for the esophageal spasm. We can use it for the biliary tract spasm. So if you know the pharmacological action, we can derive the therapeutic uses as well as its important side effect. Now coming to important pharmacokinetic. Now this is the drug, we give it by sublingual. So initially in the classification only you saw the two drugs which we give, nitroglycerin and another one is isosorbide dinitrate. We give it by sublingual route. And why we gave the nitrate for the sublingual route? Because of this drug, it undergo high first pass metabolism. And the duration of action, short acting and long acting, it depends upon if you are giving it by sublingual route, immediate onset of action, and immediately it will get metabolized. Depending on that, duration of action is there. So short acting, they rapid onset of action, immediately they come into the circulation and they get metabolized faster. So their duration of action, it is shorter. Now what all preparation we have? So we have glyceryl trinitrate or nitroglycerin. So this is the sublingual tablet by sublingual route. We give it by sublingual route. Then spray is also there. Then oral tablet is also there. Transdermal patch is there. Transmucosal tablet is there, and we can give it by IV route. This is how glyceryl trinitrate we can give. With the sublingual, it is a volatile liquid which is adsorbed. Volatile liquid which is adsorbed on a inert tablet. So as soon as you take it, how we tell the patient? We tell the patient to take the tablet, chew it or crush it so that it should spread on the buccal mucosa, and after that it will go directly into the systemic circulation and it is going to act immediately. So onset of action is 1 to 2 minutes. So patient gets relief, and half-life is only 2 minutes. So once the patient get the relief, we ask the patient to spit it out. Why we ask the patient to spit it out? To prevent the adverse effect, because patient will have otherwise headache. So this is how the sublingual spray, this is more stable in comparison to the sublingual tablet. Then we have a oral tablet. So oral tablet, this drug we can use it both for the, if you are going to use it for a longer time, okay, duration of action, if you want, you can use the oral tablet. We can give the transdermal patch. So transdermal patch, what happens? Within 1 hour, it is going to act. But after 8 to 9 hours, it does not show any effect. Then we have to remove the patch. Why effect is not there? It is because of the development of tolerance. I will be taking it under the adverse effect. So because of the development of the tolerance, the transdermal patch, it won't be showing any effect after 9 to 10 hours. So you have to remove the patch for 8 to 9 hours, and again you can use it. Then transmucosal tablet under the gums, you can like a chew gum, that is also available. And IV preparation, we can use it for the myocardial infarction. For the unstable angina, we can use isosorbide dinitrate. In comparison to the glyceryl trinitrate, it acts slower. Okay, 1 to 2 minutes, it is going to take 3 to 4 minutes or 4 to 5 minutes, and its duration of action is also 5 to 6 minutes. So this is also be given by both oral route as well as by the sublingual route. So all of them, they undergo high first pass metabolism except this mononitrate. This does not undergo high first pass metabolism. So no high does not undergo no high first pass metabolism. Whereas this, where we have a tetranitrate, they're the longer acting preparation. We can use it for the prophylaxis. Okay, we have an oral tablet, so we can use it for the, and this is also a short acting. These are the various preparation of the nitrate. Now where we can use it, so we can use it, you can remember it by A for the angina. We can use it for all the three type of angina. For the classical angina, already I have told, they are going to act by decreasing the preload. Vasospastic, by causing the dilatation of the large coronary artery. So in the unstable angina, which is a pre-infarction angina, how this drug it is going to helpful. See, in unstable angina, always remember unstable angina or a pre-infarction angina or angina, what is the main cause of this angina? Reduced blood supply. Remember one thing, there is a reduced blood supply. Now this reduced blood supply, it is going to cause the ischemia. Now because of that ischemia, what will happen? This can lead to even fibrosis. So the pumping ability of the heart will be compromised. May go for CHF. Okay? Even the conduction part, that is also hampered. So it can lead to various type of arrhythmias. So here nitrate, they are going to give only the relief of pain. But this underlying pathology, ischemia, it leads to fibrosis and all that. So we have to give the multiple drug therapy for the unstable angina or for the myocardial infarction. So in unstable angina, this drug, it is going to take care of only pain. That further progression to its for the to prevent its progression to MI, we have to give the multiple drug. Now in unstable angina, how we are going to give this drug? Only for the pain relief. So this drug you are going to give, how many tablets you can give? Maximum the 3 tablets. Okay, you will be giving 1 tablet. It is going to act in 1 to 3 minutes, 1 to 2 minutes, and just wait for 5 minutes. If the person gets relief of the pain, it is okay. But if the person does not get the relief of the pain, after 5 minutes, give the second tablet. And the same way you have to see if the effect is there, then you can stop. And if there is still patient is having the pain, you can put the patient on the third tablet after 5 minutes. So 3 tablet at the 5 minutes apart. Okay, so this is going to take care of the pain. Now, second one is a B, stands for the E. B is for the biliary spasm. So it is going to cause the relaxation of that muscle, biliary spasm. If it is due to morphine, okay, it is going to take care of that also. C for the congestive heart failure or acute left ventricular failure. Now what happens in the congestive heart failure or acute left ventricular failure? It is going to decrease the preload and afterload. It is going to decrease the cardiac work which is required. So there will be what happens? Improvement in the left ventricular function, and it also causes decongest the pulmonary. It decongests the lungs. So IV nitroglycerin, that is the choice, but we can give the sublingual also. Then another one is under this comes a unstable angina, so you can avoid this. So under C, all the condition related with the CHF acute and even for the myocardial infarction. Here also, in the myocardial infarction, we give the IV nitrate. It is going to take care of the pain. ठीक है, आपकी pain ठीक होगी इसमें. And here also you can give again the 3 tablet at the 5 minutes apart, and then it is going to take care of the pulmonary congestion. It is going to decongest the lungs, and it is going to prevent the further that whatever oxygen demand is, that compromised oxygen demand, it is going to take care of that. But before putting the patient on myocardial infarction on this nitrate, let's look at the blood pressure. The systolic blood pressure should not be less than 70. Less than 90. It should not be less than 90, and heart rate should not be less than 50 or more than 100. And if the person is, look at, if the person is taking any other vasodilator, sildenafil or any other excuse me, if the person is taking any vasodilator, then also this drug should not be given. So this is A, B and C. I have covered C, under the C all the condition related with the heart. And then coming to the another C, that is a cyanide poisoning. I'll take up this up. And the E is esophageal spasm. So A, B, C, D. A for the angina, B for the biliary spasm, C for all the cardiac condition. Under that comes congestive heart failure, left ventricular failure, myocardial infarction and cyanide poisoning. And E for the esophageal spasm. Now, how to treat this cyanide poisoning, or what happens in the cyanide poisoning? So in the cyanide poisoning, what happens? This cyanide, it shows affinity with the cytochrome oxidase. How we are going to treat the cyanide? Cyanide, it is going to show the affinity for the enzyme, mitochondrial enzyme cytochrome oxidase, and this is involved in what? In electron transport chain to produce ATP. Now what happens? The cyanide, it binds with this. Okay? Cyanide, it is going to bind with this and it is going to inhibit this. There will be no production of ATP. Once there is a cyanide poisoning, then what will happen? No production of the ATP, and this is how the toxicity happens. Now you have to give the compound which has got more affinity for the cyanide as compared to this cytochrome oxidase. So we have the three things. One is nitrate, another one is hydroxycobalamin, dicobalt additate. Now what this nitrate they are going to do? See, cyanide, it has got more affinity with the methemoglobin. Here we are going to use this property. So cyanide, it has got more affinity for this. So once we are going to give this, then what will happen? It is going to leave this cytochrome oxidase. So how it is going to this one? So what we give sodium nitrite. You can see in the next slide, we give the sodium nitrite. So this is how we can use it for the cyanide poisoning. What happens if you are going to give the sodium nitrite? Why we are using sodium nitrite? Because this is the least vasodilator action that is seen with the sodium nitrite. So this is going to convert hemoglobin into methemoglobin. Now cyanide, it has got affinity for किसके साथ है? Methemoglobin. It is going to bind with this and cyanomethemoglobin, that is one. But this is also toxic. Then what we are going to give? We are going to give the thiosulfate, and this sulfate and cyanide, they get exchanged. Sodium thiocyanide, that is formed, which is excreted in the urine. This is how the nitrate, that is sodium nitrite, we are going to give. That is going to convert this hemoglobin into methemoglobin. Cyanide, it binds with the methemoglobin, cyanomethemoglobin, that is formed, but that is also toxic, so we have to give sodium thiosulfate, and ultimately sodium thiocyanate that is formed and get excreted. Then this is a hydroxycobalamin. This is a one vitamin. It is a vitamin B12. Once you are going to give this, it is going to form cyanocobalamin, the another form, but this is a non-toxic. And this is the antidote of choice, and usually we give it in the fire accident where the person they inhale the smoke, and in the smoke the cyanide compound that is present in very large quantity. Then the next one is a dicobalt additive. This is another compound with which the cyanide binds, but what happens, this only if you are very much sure, only in the confirmed cases of the cyanide poisoning you have to use, otherwise it itself is a toxic if it is a non-cyanide poisoning. So this is about the cyanide poisoning. What are the other important adverse effects with, so these are the therapeutic uses of this: A, B, C, D and E. Okay. C, D is not there and E is there. Now coming to its adverse effect. So adverse effect, that they are the extension of the pharmacological action. So most of the adverse effect they are due to the vasodilatation. So what will happen? There will be headache, throbbing headache will be there, and then flushing will be there, weakness, sweating, palpitation, dizziness, fainting. These are due to orthostatic hypotension. Rashes, they are rare. Then methemoglobinemia. This is another. So methemoglobinemia, it is not that much significant, but if the person is anemic, then it is going to definitely affect the oxygen carrying capacity of the blood. So this is another. Then rashes, tolerance and dependence, because it shows the dependence, so withdrawal that is should be gradual. So any drug, if it shows the dependence, then we have to withdraw it gradually. Now coming to the tolerance. Now what is the tolerance? If the nitrate, it is present continuously in the body, then what will happen? It is not going to show any effect. If it is continuously present in the body, then it does not show any effect. This is what we say tolerance. But this tolerance, it is only for very short lasting. If you are going to take off the drug for few hours, then what will happen? Again the person shows the effect. So how to treat the tolerance? You can give a nitrate free interval of 6 to 8 hours. Okay, so this is the way how you can prevent this tolerance. So there is another important this one, that is a, so tolerance is an important short one, Monday's disease. How this tolerance it is related with this Monday's disease. So nitrate, already I have told ki nitrate, it was where main component of the explosive factor. So nitrate handler's headache. This point it is important. So nitrate handler headaches, what happens? The people who were working in the explosive factory, they used to have the headache severe on the Monday, but not so bad on a Friday. So this is a tolerance. Tolerance is shown to its adverse effect as well as its pharmacological effect. Now adverse effect इसमें क्या है? The vasodilatation or throbbing headache. Because of the vasodilatation, it is going to cause the headache. Now the person who is working in the factory, they are having the headache. The first day they will be having headache. Suppose if the week Monday headache will be there. Tuesday, headache will be there. Wednesday, it will be less. Thursday, it is less. And Friday, it may be negligible. Saturday, no. Then there is a Sunday, or if there is a off, then what will happen? यहाँ तक क्या हुआ? Why this headache it is less? Because of the development of the tolerance. Now this is the nitrate free period. Now what will happen with the nitrate free period? Now tolerance it weans off. Okay. Now the person goes to the factory on Monday, and again the same thing will happen. That's why it is called the Monday's disease. So they say if it is showing the tolerance is with the adverse effect, then definitely it will be to its anti-ischemic effect. The tolerance will be exerted to its anti-ischemic effect. So if we are using the nitrate for the acute attack, so for the acute attack where we are going to give it as and when required by the sublingual route for the acute attack. Okay, we are giving it sublingual, or any tablet if you are giving as and when required. If you are giving to give it then there will be no development of tolerance. But if you are going to give it for the chronic prophylaxis, if you are using it for the prophylaxis where you have to give it continuously, then the tolerance develop, and what will happen now, because of this tolerance, this anti-ischemic effect won't be shown. So how to treat it? You can give a nitrate free period. Same, the treatment is same here, nitrate free interval. So ask the patient not to take on daily basis. Ask the patient not to take the nitrate after 6 p.m. and before morning. You can say 8 to 10 hours. So ask the patient not to take it before 7 a.m. or 8 a.m. morning mein. Okay, so this is how you can treat it. So that's all about the nitrate. So here, what kind of questions you will be getting in the exam? Classification of the anti-anginal drug, that is very commonly asked question for the MBBS students. And then another one is what is the mechanism of action of the nitrate, its therapeutic uses and adverse effect. So this is a very important question as an anti-anginal drug. Then the adverse effect as such can be asked as a short note. Then in the adverse effect, the tolerance, that is very, very important. Then in the MCQ, what kind of question can be asked? The nitrate, they are useful for the classical angina. What is the mechanism of action? They are going to decrease the preload. Nitrate, they are useful in the prinzmetal angina or a variant angina. What is the mechanism of action? It is because of its vasodilatory effect. Then the first pass metabolism, why it is given by sublingual route? Okay, which drug it does not undergo first pass metabolism? Which nitrate? It is isosorbate mononitrate, that does not undergo first pass metabolism. So that's all about the nitrate. So if you like my video, please give a big thumbs up, share it and subscribe my channel.